Okay, we are live.
All
And
right.
let me just double check here that everything is streaming okay. And we'll go ahead and get started. Okay, yep, looks like we're on
Sounds
here.
good.
Okay, good. So, um, we don't have anybody watching yet, but we know we're going to leave this as recorded so people can come back
Yeah.
and watch it too. So we'll go ahead and just kind of get started on our topic. So I thought maybe we could introduce ourselves. We're back again.
Yeah.
um, we'll just introduce ourselves and then we'll kind of pick up with our topic for this evening. So why don't you start?
All right. Good evening, everybody. My name is Dr. Bethany Ketchen. I'm a clinical psychologist, and I currently work at the Atlanta VA healthcare system as a program director for a treatment program for veterans with history of substance use disorder and lack of housing or unstable housing.
Thank you.
Baby
And I
and
am Leigh Ann
everybody.
Dooley. I'm a psychiatrist. I also am back working for the Department of Veteran Affairs now for the Augusta VA. And so I am providing virtual care. So I'm physically in Atlanta, but providing outpatient mental health care to veterans in Augusta. And before we go any further, I just want to give the disclaimer that the things we're going to be talking about today, they're for informational and educational purposes only, and they don't constitute individual medical or mental health advice. And all the opinions that we talk about today are our own personal opinions, and they don't reflect the opinions of the federal government or the Department of Veterans Affairs. So we'll just get that out the way. Um, so thank you for being here, Bethany. We're going to be talking about a topic that's really important to me, and that is women veterans and mental health. Um, and I have a little factoid here that um, in 2000, women were only about 4% of the veteran population. Hey, had a little glitch there, so
That's
it's
how
okay.
technology works.
I was just getting started. I was basically just giving that kind of disclaimer. I finished that and basically was just saying that we're just here tonight to talk about an important topic and one that's important to me and you, and that's about women veterans in general and also women veterans' mental health. So
Absolutely.
thank you for being here for that. And I was just starting out with a little factoid I have here, and it is that in 2000, women were about 4% of the veteran population, and by 2040, it's estimated they'll be 18%. So definitely in the time that I've been practicing, period, mostly in the VA hospital system, I've really seen an increase in the number of women who are seeking care there. And what do you think? Like, is that kind of your experience also?
I would definitely say so. I would say that though I've mostly been pretty much exclusively in residential services from my time working in the VA, that I really have seen just an increase of women accessing care, young women accessing care, and also I think an increase in the focus on women veterans and creating basically a space that women know that they were part of the thought process in the services that are being provided at the VA. So I would agree and that women are more present and that the VA has had more of a focus on them as well.
And what would you say, just kind of in general, are kind of issues that you see women veterans having, like accessing care in the VA system, just like general things?
Um, so I mean, I think I was looking at something earlier today just to kind of look at some of the demographics of women who are using VA care, and I think a large number of women who are accessing VA services are between 18 and 44 years old. So a lot of them may have younger children. So I think one of the things I think that can be challenging for women to access care, women veterans and women in general, is being able to balance having young children and seeking services. And I think the VA has historically maybe not been so child friendly. So there, and just so in terms of like the physical space and everything that's there is not necessarily set up for people coming in with young children that need to wait with them. I also think that I was talking to a couple of women veterans earlier today, and part of what they were, what one in particular was talking about, a challenge that was there for her is feeling like other people needed the services more than she did. And
Okay.
so, really, that um, she felt like she was taking away from other veterans by seeking care. And so I think also getting over that hurdle of belief that my problems aren't as big as others, or that I just don't have necessarily a not a right, but that I don't need these services as much as someone else, and not wanting to be a barrier to someone else receiving care that they need.
That's really good to hear. I hear that sometimes, just like in also people feeling like, well, I'm not missing a leg, or I don't
Right,
have this. I don't. Why would I go to the VA? And it's like, well, you can go there because the care is tailored to you, and also
right.
you earned it.
You earned
So
it. Hmm.
that's thank you. That's a really good point there too. And I think it's when you say that about the physical space, I think about just some of the clinic areas that like we worked in, and they definitely aren't friendly. Definitely though, they're in some of the women's clinic, definitely in Atlanta, they have kind of like a play area. It's a little more, I think, with the thought in mind that the women
Hmm.
coming in there. I don't know if you've ever been in there, but they actually do have it set up as if that thought was in mind.
Hmm.
But honestly, I'm thinking like waiting areas, even like what's on the TV. Like usually, it's not something that probably would entertain a child. So that's actually a really good kind of observation there.
Yeah, and I remember there was a couple of years ago another psychologist who worked in a different area of the VA hospital in Atlanta. That was an initiative of hers, is really recognizing that we have really families who are coming in to seek services, and we need to be family friendly. And so she had an initiative to get some tables with books for kids and things for kids to put in waiting areas, but along with women's wellness, but in other clinic areas as well, because families are seeking services throughout really every area of the VA.
That's actually a really good point. And I think, one of the things that's striking to me is because I think the shift in the women, they're younger, is
Uh-huh.
that when women would get pregnant, I
Oh
feel
my.
like all like heck would break loose. People would be like, it's a pregnant woman. And definitely I think in mental health, because a lot of the psychiatrists, particularly people who are prescribing, hadn't probably seen a woman, maybe a pregnant woman their entire career, because it just
Mhm.
wasn't there. But I think in general, when there's a pregnant woman, sometimes even I think in primary care, they're like, why aren't they seeing? I'm like, well, you're still their primary care. If this was in the community, if they were pregnant, you still will be treating their fill in the blank. But they're like, but I've never treated hypertension in a pregnant woman. Okay, well, that's a base like competency for like a family of medicine. So you got to get up to speed. So I think too, just particularly for practitioners who've been in the system a long time, that they really may have not ever seen a pregnant woman or managed
Yeah.
like cholesterol or diabetes, like basic things, but in a pregnant woman, like
Mhm.
someone in the community was. So I think that was like when I started seeing more women in the VA, like striking to me, like she's an
Mhm.
alien. Like I'm like, women get pregnant, like particularly in that age group.
Yeah, I'm like, it's a thing that happens. It happens. Like,
Right.
pregnancy happens. It's not an infrequent phenomenon. It does occur.
And we have to like get on board to know how to do those things. So I think that was, I think, a particular challenge, the providers not being just due to the fact they hadn't seen a pregnant woman or managed those conditions, really not knowing what to do or what the
Mhm.
standards were. So
The other thing, just before we move, because I can see you're preparing for the next thing, but I just wanted to also add in, like, I've talked to a number of women who have gone in for care. They are the veteran, that they may go in with a male partner, and the assumption is that the man is the veteran. So I think that that can also be kind of like off-putting, or just for people to be mindful of the fact that women have served, and they've served for decades in the military. And so that, and not necessarily assuming that the male person that a woman is with is the one who served in the military, but to keep your minds open to that the veteran actually may be the woman. Women have served for quite a long time.
I know one group, I when I put this live together, I used a hashtag, and so I kind of looked at some things on the hashtag under women veterans, and there was a post where a woman had uh, was the disabled veteran,
Mhm.
and as we know, all disabilities, even physical ones, you can't see right away. And so she had parked she had a placard, with a wheelchair on it, so she could park in a disabled parking space. And someone came and wrote a really nasty note and basically said these parking spaces are for disabled veterans. And it kind of speaks to what you said, like not even thinking that this woman, is just wrong, but she's a veteran, that she could be disabled and that she could have something physically going on with her that wouldn't be immediately apparent, like a lot of conditions. So that's really a good point too, that somebody would go and like put that note on her car. That wouldn't give you a good welcoming kind of feeling going in for your care when you came out with that.
No. And I think about that, like imagining, that when you walk into the VA as a woman, whether or not you're on staff or as a veteran who is seeking services, you are definitely in a noticeable minority. And so I think the hump of even going through the door, walking in to receive services in a setting that is very much predominantly male, can be a barrier to accessing care by itself. Especially, I think, and I know you're going to talk about this, and I don't mean to steal this particular statistic, around 1 in 3 women reporting a history of military sexual trauma. And so going in, and many people still do see the VA as an extension of military and of their active service, that in itself can be a hurdle to women veterans accessing services in the VA. So.
And I think, like you said, whether you're a staff person or a woman veteran, I think we both kind of experienced just, what it can be like going in kind of these all male spaces with like comments or stares or things like that. And so I think it's important for people to really kind of keep that in mind, period, right? We want to be respectful in our communication, but we never know what people are coming in with, and how that kind of thing might impact them. So, any other kind of general kind of comments or thoughts? And that kind of really sticks out to me.
No, I don't think so. Not right now. I think that was good.
But given that statistic really kind of segues us into what we were going to talk about next, which is like mental health concerns of women veterans. And like you said, 1 in 3 women report having military sexual trauma. So for people who are watching who don't know, the military, and I guess the VA as an extension, has their own definition of what military sexual trauma is. So that term basically encompasses everything from harassment, any kind of unwanted verbal or physical attention, all the way to like a sexual assault. And so that term really encompasses all of those things. So when we talk today, we'll probably just say MST because that's what we call it for short. But that really is the way that the military has kind of defined and encompassed all areas of really unwanted contact of that sexual nature. And I know we were talking before. I know a lot of women veterans think that if they maybe aren't service connected, and again, for people watching who don't know what that means, service connected means that you are getting a percent or a financial payment for a condition you developed in the military, basically. And so some women will feel that if they're not service connected for PTSD or have their sexual trauma documented or have it like adjudicated in a court, that they can't get treatment for it. And so I know one thing we wanted to do is definitely communicate that you can get treatment for it. Even if you never reported it when you were in active duty service, you can get treatment for it. You don't have to be service connected or have gone to court or anything. You can come and you can get treatment. And we provide treatment based on your report. So we don't have to do investigations. We don't have to talk to people to prove it. Like if you come and you say you've experienced these things, we will treat you for it. So I think that's really important because I do hear that. Like people say, oh, I never thought I could get help because I didn't tell anyone when I was in the service. And I think as it relates to sexual trauma too, one thing people don't think about is that there's lots of men and women just due to the nature of the number of men. There are a lot of men who've had military sexual trauma too, even though we tend to think about it more in women. What would you say as far as just like your kind of thoughts about mental health concerns and women veterans and like challenges and things there being in the system?
So I know, I mean, I think we were talking about this maybe a little while ago, is that a lot of the mental health concerns there are similar to the ones that we see in the civilian population. So definitely depression, anxiety, substance use disorders are certainly present amongst women veterans, as you know, and you know, those diagnoses are similar to in the civilian population. PTSD as well. I think for women experience PTSD for a variety of reasons, including as a result of events that occurred in their military service. One thing that I know we were talking about as well is I think one of the challenges that women veterans have faced in the not too distant past was also being recognized for combat service, because it was not necessarily, or it was written into the policy that women are not to basically be involved in combat operations. When women served, especially during these, like the Iraq and Afghanistan wars, and were attached to combat units and engaged in combat operations as being attached to those units, because war does not work the way that it's not an organized or orderly fashion, is being recognized for that service, having that acknowledged, and having their experiences being validated for that when they're coming to receive mental health services for symptoms of PTSD.
Yeah, and I did not know that like until you told me that earlier. I didn't realize that. I mean, clearly they were involved, and we know in different using their weapon, and other kind of combat just actions. But I didn't realize because the policy was there, they couldn't be recognized. Because we also know that having a combat veteran status entitles you to different
Right.
types of benefits and services too. So I'm glad you shared that because I didn't know that either.
And I know I was talking to you about this documentary, The Lioness. So I think the documentary came out maybe around 2008 and was talking about the service. They followed these 5 women who served in Iraq. I think it was between 2003 and 2004. But for anyone who's interested in just kind of gaining some information about the experience of some women veterans, like during that particular period of service, The Lioness is a great documentary to check out. And so
I hadn't heard of that either, so thank you for
yeah.
sharing that. Yeah. I was gonna say also, I think that, like you said, as we know, like a lot of anxiety, depression, these kind of common the situations that come up there. Well, you mentioned earlier that you're in a residential treatment program, so I thought maybe you could kind of talk to the audience about what that means exactly.
Mhm.
And just as you know, for the people who've seen our other live streams, they know we used to work together. So I also used to work in the same program. And so I think you start by just kind of talking to us about what residential treatment is. And then I can kind of chime in just kind of some of my thoughts too about the challenges kind of being in that setting.
Yeah. Do you mind if I go back just for a second, and then I'm happy to, because I think the other thing that I had reached out to just a couple of people to get their thoughts this morning, and one of them was the women veterans program manager and everything from the VA that I work in, and I was just asking her about like some questions about what do you think are some of the things that may impact veterans accessing care as a whole and mental health care in general. And what she wrote back, I just didn't want to miss an opportunity to highlight this piece as well, is really the fact that in her experience, a lot of women veterans that she's come into contact with feel like the problems that they have in their life, they should be able to manage on their own. So they should be able to just continue to power through, push forward, and take care of it on their own. And that sometimes it is really taken connecting that woman with another woman who is already receiving services to help encourage her to connect to care. Because while on the outside looking in, it's apparent that intervention would be helpful here and everything, and help this woman who is trying to carry a load that is much greater that any individual should carry. Sometimes that connecting with another woman to help them over the bridge has been really helpful. But that I think is impacted and everything. That can be, I think, a variable in some ways, not unique to people as a whole, but I think especially in this population of a veteran population where to be strong, to be tough, to persevere, to push through is definitely really core to their identity in many ways. So I just didn't want to miss the opportunity to talk about that piece. But I'll talk about residential all day. So,
but I'm glad you brought that point up too, because I feel like for some people, they don't like to share that they're getting care in the VA. I think there's like still some stigma associated with it. So I think it is a good point to make. It so important that maybe if you are, or maybe if you know someone else and they're struggling, right? I think that's the plight of women in general, right? Is to put other people's needs before our own. And then that, like you said, that military culture. I just saw a new female woman patient, and like this lady is like so emotional, tearful, and I'm asking her, how long have you been feeling sad? And she could not say she was feeling sad or have been feeling sad. She just kept saying, I know I can't. That's weakness. That's what she just kept repeating, despite the very obvious fact that she was having these feelings. And so I think that just speaks to the military culture. Like this person was in the military and retired, so has spent a whole career. So of course that thought is there. But even in this appointment, like even with, to the point of almost having tears, could not say that. So that really does speak to the strength, it was the strength, just how ingrained it is.
How ingrained it is.
That it's weak to admit something like that. And then, okay, let's go to residential. So we know you talk all day about it. So maybe just explain to people what it is, and and then I'll kind of chime in, but we'll start with you telling us what it is.
So residential treatment services is definitely part of the continuum of care. So most people are familiar with outpatient services, like when you go for an outpatient visit to see your provider for maybe a 50-minute therapy session. Or there can be more intense outpatient programs where you spend several hours a day there, but then go home at the end of the day. And then inpatient psychiatry or inpatient care is on the other end of the spectrum, where you are in a setting and it is not so easy to leave that particular level of care.
You can't leave, you're locked in.
Exactly. It's more of a locked program or setting for maybe mental health reasons. And so residential falls in the middle. So it's more intensive level of care, and usually an interdisciplinary team of providers. So psychology, social work, psychiatry. We are fortunate enough to have chaplaincy, voc rehab, but very much an interdisciplinary team of providers to provide 24/7 care. Nursing is definitely quite a large component. And that setting is really for folks who have had a hard time essentially managing either substance use disorder, symptoms of mental health disorders on an outpatient setting. So they need something more structured. They need more round-the-clock services in order to help them continue to work on mental health, substance use concerns, or other like psychosocial challenges. So they maybe have had a history of justice involvement, a history of homelessness, those kinds of things. So it's a structured setting. And so within the VA, certainly we have residential services. We have residential services here in Atlanta. And within that, we have a designated number of beds for women veterans. There we have, just to speak specifically about Atlanta, we have 10. And then we have 51 beds that are there for male veterans. And so you can see that while we do have space for women, even if we're completely full for women, there's 10 women and 51 men, and navigating a very much shared space. And so I think even kind of recognizing how numbers matter and everything, and how one might feel being in a space all of the time, and having your own histories that can add complexity to how you respond in that kind of an intense interpersonal situation. That challenge can be greater when you are one of few.
And I definitely know, like in our time, like working there together, because the patients, they live there, right? And for the time that they're there, it's their home. And we know that people just have different habits in their home and ways of doing things. And so I think Definitely one of the challenges I noticed is that, and I think part of it is just, people are just different. They have different ways of communicating, and we have different views just as humans as like what's an appropriate form of communication. But I'm just
Mhm.
thinking now to the number of like talks with the community I would have to have about,
Mm-mm.
let's just call people their name. Let's call people not honey or sweetie
Mhm.
or I mean, I mean, like multiple times we had to have like a whole group discussion about that. And even, I don't know if you remember this time, but one of the patients had held the door for a woman and she didn't want it to be held for her. And she,
Mhm.
I was like really upset about that. I don't know if you remember, but we had like a whole meeting about it, and how some people position their body in a way. So as a
Mhm.
woman, when they hold the door, you have to kind of touch them as you go in, and I feel like I could tell that most of the gentlemen there didn't even think about that, because most people don't have those kind of intentions, but like we were saying, we don't know what kind of experiences people are coming from, and when you're in there with that many men, and so I think just having that basic kind of conversation around like boundaries, in a
Mhm.
setting like that. Like, it's okay if the woman doesn't want you to hold the door. It's not personal to you. We don't know what her, that person's, or even another gentleman for whatever reason. If they don't want it, like, it's okay. They're not being rude to you. And definitely that, like, let's just call people their name. Let's not call them anything but.
Straightforward. I'm like, just do that. Like, let's just do that. The thing too, I think like one of the things I've always loved about residential and can just appreciate about like just VAs nationally is that just because you're in a state doesn't mean the people who are receiving care there are from that state. So the VA definitely draws people from various places around the country. Also, like there's diversity in the age of people who are there. So you have folks also who are used to a different time and everything where or a different geography where a honey baby sweetie is part of what they're just like, but that's just what we did, and everything, like I don't mean anything by it, that's just what we did. So I feel like that definitely creates challenges, but it also creates opportunities for growth, learning, and awareness, like what you're talking about is like you women are not I wrote this earlier because I thought it made me sound fancy. Women are not a monolith and everything. So,
I like that vocabulary word.
right, I was like, I did that earlier. I was like, I'm gonna write this down. It's gonna make me sound good. Women are not a monolith. So, I mean, just because you're used to this, maybe with your aunties or the women in your family or the women you come across, does not mean that every woman will respond the same way to your actions. And the asking, getting information, and respecting the differences are also a big part of the picture. And I think that's too, and for us providers and how we provide care. So for and really asking the individual women who are woman who is before us what their preferences are in terms of how they would like to receive their treatment, from whom they would like to receive their treatment is important. So assuming that all women want to be in women only groups or be, have a woman provider is basically an assumption, maybe based on what you would want or what you think women would want. But it's important to ask because not every woman is the same. Women have different, preferences for that. We did, maybe this was about 5 years ago or so, a needs assessment for women who were on the acute psychiatry unit. And that was exactly the responses that we got. And some women said, yes, I would like to have some groups that are women only, but not all. And some women were like very clear, I want to be in a room next to another woman. For other folks, they really didn't have that preference. And so I think that's important for us to remember just as providers is not assuming that every woman is going to want the same thing in terms of how they receive their care.
And can you speak a little bit to when there is a transgender patient in the residential setting? Because I know just like some of the challenges like we kind of would face in that. And can you just like speak to kind of how we like would navigate that?
So I would say that the general stance is that we honor the individual. So if the individual identifies as she or her, we honor that. If the medical record may have a different name, but the veteran has a name that they have chosen, then we honor that. Like we honor the pronouns, we honor the name, we also honor their living arrangements. And so the living arrangement that a transgender veteran would have would match their identity as they see it. So we certainly have had transgender veterans who have been in the program who live on the women's hallway in a woman's room because they are a woman. And so so we honor that. There definitely, I think, is challenge for some staff. And but we maintain the same, I think, policy and practice is that we respect the individual. And that's just the bottom line.
I just wanted to be like sure in our conversation that we just like made that explicitly clear. Just in case anybody was wondering, but it's like if you're
a woman, we don't play those games. We don't do that.
And I think one thing that I always, like respected about you is just kind of maintaining that stance. And I know we were all like on the same page about that. And, even I think we had like a little in-service at one point where we talked about, this is what, gender dysphoria, gender identity, like these are the things. And, it's not okay to use certain terms even, amongst ourselves. I think as mental health professionals, we use a lot of humor just due to the nature of the things we deal with. But, there are times where just certain things just aren't okay. And so I was always glad that we were kind of in the same mind about that.
I remember, and I appreciate it as well. I think there was an instance that came up because that you were kind of pushing further around like why is it that a transgender woman would be in a single room, single bathroom? Like, why is it that they would not be in a room with a shared bathroom? They're not going to be in there at the same time anyway. Who is? So why is it that we have these boundaries around things? So thinking really about the decisions that we're making and would we be so concerned under other circumstances? And no, we wouldn't. But I think that we have always been on the same page about that. No, we respect the individual.
Mm-hmm. Good deal. Yeah, I like to be sure that people that people know that about us. Mm-hmm. I'm saying like when we were working together, but just in general, I mean, we're going to respect the person in that way. So
yeah, and educate and provide. I think education, and not in a pejorative way, but education to those who may need it, and while keeping the expectation in place about respect.
And can you talk about just like some other things? I know you talked about like having open conversations about what their preferences are, just like some other things that, that we would do to kind of help make people feel safe, kind of in that setting. And I'll kind of talk about in the outpatient too.
Mm-hmm. So I think we have always maintained some groups that are for the women residents who are there. And so I mentioned that we have chaplaincy on board, and so chaplain would provide a group for women veterans, and one of the psychologists on staff would provide a group for women veterans. We would have opportunities to meet with the women as a group. I think that something that has come up just at different periods over time is that making sure that we're also, I'm trying to think of the best way to say this, but ensuring that we're providing like the same access to services to women that men have, right? So that, and these are things like hygiene. So like getting their hair cut or hair done or mani-pedis or whatever it is that the women are kind of expressing that they need to like feel like themselves and everything, because a lot of what people are receiving care for not only is about kind of getting their life back on track, but just getting back to feeling like themselves. And we always want people to feel like they're being treated with dignity and respect and they have access to those things. So making sure that we're maintaining open dialogue with the women veterans who are receiving services in residential to make sure we're attending to those needs. And then I think Oh, go
I
ahead.
was just gonna say, I think about too, like when we were having all those discussions around like visitation
Mm-hmm.
and, what can kids be in here? And, we did have some,
Oh, yeah.
kind of special situations, right? We did have people who, had sex offenses who were in
Mhm.
our program in the program. And so, we had to navigate around that. But I
Mhm.
think too, some people just really weren't on board with like children coming to visit their parents. And
Mhm.
like you mentioned kind of earlier in the chat, that's one of the main things that I think is kind of men have children too, but oftentimes women are the primary caretakers of children. And so
Mhm.
when there's a situation where mom is in a program, it's like, what can we do to kind of for men and women to like keep those connections, and especially with the moms knowing they're gonna leave it. And, I'm thinking a couple of cases where like the mom is still trying to manage the day to day
Mhm.
school and routines for kids
Oh,
when they're in
yeah.
here trying to get their own help. And I'll be honest, very rarely, and you can tell me your experience, but when I was there, very rarely did I see the men as worried. The men are like, oh, they're with my mom or their mom or whatever. I'm in here to get my treatment. But a lot of times when the women are there, they're either concerned about where their kids or even their husbands, they're trying to like get out on the weekend so they can go home and like take care of their husbands. And I that seems to be kind of also unique to the ladies. I didn't notice that as much with the guys.
Yeah, that's a good point. I wasn't even thinking about that today, but you're right. Like the women, their home responsibilities or caretaking responsibilities don't end just because they're outside of the house. You're right about that. There's not, I think, with maybe very few exceptions, women were really always had an eye towards their family and what was happening there, and that occupied a lot of their space, their mind and everything while they're in treatment. You're right about that.
To the
And I
point that
think
some people would leave early because
they
they're like,
would
well,
be
I got to go
early.
home and take care of my husband or whatever.
Yep. Yeah, you're right about that. I hadn't even been thinking about that.
Yeah. And
Mm-hmm.
again, maybe they were concerned, but it just, like you said, didn't seem to like occupy as much of like the mental space for the gentleman. They were able to really separate, like, I'm in here to get treatment. Whatever's happening at home is going to be, taken care of at home or something like that.
And it may even be like to a significant other who really, I don't mean to sound shady here, but should be able to manage their life independently without this other person. But
Yeah.
they had taken on such a role of caretaking even for another single adult that it was really hard for them to focus on their own care and stuff. So
One thing
mhm.
I think from the medical perspective that I would notice that I feel like are challenges for sometimes for ladies in the system is that, women, for example, need things like birth control, for example. And we know that sometimes the first thing we try may not work. And even though it seems the same as another pill, like maybe that one just isn't going to work. And the VA hospital can sometimes be very specific about their formulary and how many different things they have for how many choices. It might not be that many choices. It's like we got three choices, and if this third choice of the birth control don't work, and so I think just like that limitation, and I think also prescribing around like childbearing. So I know it's like sometimes maybe in a childbearing woman, there might be a medication that I would prefer because the safety profile, and sometimes there's just like extra bureaucracy to get it because the VA will say, well, we have this similar thing. And I would say in most cases, something similar is probably fine. But when it comes to a woman who's carrying a baby, you want to know that the medication you're taking is the one that has those data. I don't care if it seems similar to this. This is the one that has been studied. So that is the one that we want. We don't want, even if it's similar, we want the one that has the information available about that kind of thing. And so um, I think sometimes there are just, you can generally get it, but it's like more hoops to go through. The same with women on the end of like menopause. The VA is so much better about this. They're so much better about hormone replacement. But at one point, like if you wanted patches for hormones and you didn't have a specific reason you couldn't get it, which we know for testosterone, though, there's multiple different ways men can get that. There's gel, there's pills, injections. But for the ladies, like it was for a while a little bit of a challenge to get that. So I think they've done a good job to kind of realize that we need to open up and have some flexibility around these issues that ladies will have.
I mean, in some ways it makes sense, right? Why the VA is basically where it's like a wave. And so, because I do think, I mean, when you think about like the number of women who served, let's say, World War II Korean War era, there probably were fewer women who served at that time than there are now. And so the services really were aimed at for men and everything. Like they have had a much longer time kind of identifying, growing, developing all of the services for male veterans. And so I think, and like just kind of looking at that women's health initiative document that covers like 16 years and stuff like that, I think there is a recognition that, okay, like we need to fill in here. We have a lot of women who are accessing the VA is only going to grow. It will be women across the lifespan from 18 to 65 plus. We need to basically build our services in anticipation of what women need as well. And so I mean, I think we are in a place where there's a lot of, again, focus, attention, and new initiatives to ensure that women know that VA services are for them, are for, the services of the VA are for women as well, and having more comprehensive care.
It's like grown incredibly compared to
Mhm.
when I first like was training. It's
Mhm.
so much better, and I think just like so much more, like you said, with the woman in mind, and so much more inclusive.
Mhm.
And um, so we kind of covered one of the last points I was going to talk about, which is part of like what the VA is doing to improve care. But I did
Mhm.
want to step back a little bit and be sure that we did talk about like this kind of just like the suicide rates in women veterans, because they are higher than the civilian, as we call it, the non-veteran woman population. And just if you have any like thoughts or comments, I know in the readings that I read, they kind of speculated that part of the reason for the increase was just that women veterans, maybe more so than civilian women, have access to like lethal means
Mhm.
in the form of firearms. And I think that probably is true. And I think that does vary some by like where you live. Like in Georgia, where we are, we know that weapons are like cars. I mean, almost everybody has one. I mean, so I think, definitely, I think probably being in the South and some other places, that's more too. But just like any like thoughts or comments about like that in women, the
Well,
veterans.
I don't even know if it has to do with geographical location. I really do think it has to do with military service and comfort with the firearm. I just think, I mean, women veterans have been trained in firearms, they're very comfortable with firearms. And I think, I think that is what makes the difference in a lot of ways, is that they're going to have access to more firearms, be comfortable with them. So I think that plays and this is purely my opinion, is that is why you see women veterans using firearms as a mean for a suicide attempt or completed suicide more.
Yeah, I think the statistic I had here that in people who had a complete in women who had a completed suicide, about 40% of women veterans who died by suicide had a weapon versus about 30% of civilian
Mhm.
women. So that definitely like kind of comes out in the data. So
Yeah. And I mean, I think in any conversation that we're having now, I think just thinking about like the impact of COVID on just everything, but definitely in terms of wellness and women's wellness as a whole. And the fact that, for a lot of women in particular, the additional role of um, like taking care of children full time, because a lot of schools are closed, on top of everything else that women are managing, definitely is impacting substance use and mental health symptoms. So I just never want to leave COVID out of things, and how it's really exacerbating the challenges that we already see for women, and women veterans are certainly impacted in that group, as like everyone else is.
And I want to just say, even though this isn't for like women specifically, but when I think
Mhm.
about, like common myths about suicide, and that, myth so much there is that, if we talk about it, we're going to increase
Oh
thoughts
yeah.
about it, or we're going to increase the likelihood that people are going to do it. And I definitely think for anyone that's watching, particularly if you have a concern about anybody, but, particularly a veteran,
Mhm.
just frankly asking. Some people say, well,
Mhm.
how do you do it? Or, I'm like, I just ask people. are you having suicidal thoughts? Are you having thoughts about harming yourself? Some people may be more comfortable with that. And I think some people worry about what they're going to do if somebody says yes. They worry like, well, what if they say yes? What am I going to do? And I always say at a minimum, what you can do if you're concerned about a veteran who may be having those thoughts is you can call the Veterans Crisis Line and just like let the crisis line person in the description for this live. I did put what the crisis line number is. We know about heart because we had to put it on every voicemail
Oh my gosh.
for like years. But I just want to be sure I say that asking someone, particularly if someone has access to maybe certain medications or they have a lot of meds at home. A lot of veterans have different medical conditions. And so they, to have a lot, maybe meds potentially, or if they have access to a weapon and you've noticed the change, they seem more depressed or, maybe they've even made some comments to you like, oh, things would be better off. It's okay to ask the person. You're not going to increase the chance that they commit suicide or put thoughts in their head when they weren't there. There's no evidence that happens. And I would say in my experience, it doesn't. And oftentimes people are relieved that somebody asked them. And for me, it's also to say, just because you say that, another thing that people think is you automatically will go into the hospital. And that is not true. That we don't even have enough psych hospitals enough to admit all the people who say they have suicidal thoughts, right? So it's based on like what your risk level is for harming yourself. But I did want to just say that if you are concerned about someone, you can just ask them. You're not doing a bad thing if you ask them.
No, and I think that you're right. And thank you I appreciate that you also are just highlighting the point that people often feel relieved that somebody has noticed and everything. Is like, oh, you see that I am struggling and you're taking the time to call to ask me, how I'm doing and ask if I'm having thoughts of hurting myself. And the more comfortable you are with asking, the more comfortable the person is usually letting you know what's going on. And just I know I'm repeating, but I feel like it's worth repeating that it does not have to be the veteran themselves that calls the crisis line. You can call or text on their behalf, and someone will return that text message or return the call, or pick up the phone and everything and speak to you as well. So you don't have to wait for someone else to call. You can call for them.
So if anybody has a concern about someone and one of your concerns is what are you going to do if they say yes, just know that no one expects you to be their psychiatrist or their therapist. Get that number, keep that number and you can call, so definitely want people to leave this live knowing that if you're concerned about someone, we don't expect you to be their mental health provider. Call that number. All right, well, let's see. We have about 10 minutes left. I've been kind of watching the chat. We have some comments, but no questions. So I thought maybe we could end by just kind of talking a little bit about some of the resources that we know about and that you were telling me about some new resources for women veterans. And I'll compile that and I'll have it in a document. So for anyone who's interested for this list of resources for women veterans, you can DM me and I'll also include the information out in a separate post I'll do here on Facebook. But we kind of just talk about some of the resources we have.
All right. Do you mind if I just go back again one more? I know I just keep saying, can I take it back one more time?
Go back, yeah.
Because the other thing I just wanted to say, I was looked away at my notes for just a second about like what was helpful when I was talking to a couple people about like what helped them get over the hump and to access care. And just to, again, that part of it was really, one woman talked about how her sister works at the VA, and essentially, and that her sister is basically the person who encouraged her to go ahead and connect to services, even though she felt like that other people had more serious illnesses than she did. But really having like for I think, and anyone can serve as that person or encourager. If you know a veteran or, any veteran or definitely a woman veteran who is hesitant about engaging in care, is to basically is to assist them. Basically is to give them information, offer to call with them, offer to go with them to appointments once the world opens up a little bit more again and stuff. But I think it just can't be underestimated how beneficial it is to have a link. and stuff, and to have someone who is willing to basically help you navigate what can be sometimes a challenging system for anyone to navigate entry to, especially. And
Yes.
so I think has, and a couple of people that I had a chance to talk to earlier today, all of them said that part of what helped them go and start accessing care that they really have found beneficial is having someone kind of walk through it with them. And so, sorry, I just looked aside and I just didn't want to miss that.
No, thank you for making that point. I mean, there is so much that's available. For me, it really is sad that people don't know all the things, especially women veterans, all the things that you can have access to, all the programs, all the benefits. So,
Oh my
if
gosh.
it takes us going to an appointment with someone to kind of help them get connected, then it's like be that person that helps a woman veteran get connected to care.
Mhm.
Um, but yeah, we'll move on. Like, what are some resources? You were kind of telling me about something new that I didn't even know about that I learned today.
Yeah. So again, like in these conversations, because I was like, I have to be prepared because I know Dr. Dooley's going to be asking me some questions about some stuff. So let me reach out to people who know more than me about like this topic. So I reached out again to the Women Veterans Program Manager, a couple of women veterans that I know as well, and two of those women are involved in a military sorority. So there are a number of military sororities. It looks like the majority of them are relatively new. So within the last 10 to maybe 12 years that they've been established. But they really are, and there are military fraternities as well. There are co-ed organizations that kind of serve the same purpose. So there's a lot out there, maybe to meet your particular needs or interests. But they really, these sororities are definitely focused on creating community and like maintaining the camaraderie that women felt while they were in active duty service. And also committed to community service, serving the community, mentorship, providing support. One of the women I talked to serves as a chaplain in her sorority. So really providing like that kind of spiritual support as well. They have webinars. One is coming up from this particular organization on managing stress. And so it sounds like they really are there to basically provide to be a source of support for women who have served in the military. And then I guess like everything else, everybody's got social media presence. And so there are Facebook pages for military women. So in the state of Georgia, there's like Georgia Military Women's Facebook group. On there, they have a number of resources, but they also are a platform specifically for women who have served in any branch of the military. And so there is a lot in everything that is out there. And as the number of women continue to grow, the number of women veterans continues to grow, as it definitely will. Those organizations, and I'm sure the number of those organizations will continue to grow as well. So that was something really cool to hear about, learn more
You
about.
mentioned during this the stream about the women's veteran coordinator, and do I remember this correctly? Every VA facility has to have one of those, right?
Every VA facility has to have a women veterans program manager. They have to have an intimate partner violence coordinator. And they also have to have basically a women veterans like group under the EEO, essentially like equal opportunity, like although umbrella for lack of a better or program at every VA. Mhm.
Okay, I thought so, and I think that would be helpful for, let's say, again, someone new to care, accessing it. You can. I find that when I'm looking for that the information seems to be fairly easy to find compared to other um, positions in the VA. So you maybe
Uh-huh.
could even just Google like women's program manager or coordinator for the VA you're at, if as a starting point, if you're trying to access care, or maybe if you're having an issue in your system and you feel like you really, want to advocate in a woman to, that may be a place to
Mhm.
start to kind of get connected to the things you might be feel like you need.
And I know I saw this on your resource list as well about the Women Veterans Call Center. So that it's a call center line specifically for women veterans. It's man only by women. And so any woman can call to find out what services are available, to inquire about eligibility for VA care, and talk to another woman on the other end of the phone. So if that makes it easier to call and to connect to services and learn about what you might be eligible for, then that is there as well.
All right. Well, we are getting towards the end of our hour. And let me just scroll through. Again, I see some comments. Um, okay. I see a comment about the hair, but that's my cousin. So we're going to just thanks, Daryl. Thanks for that.
She said
But
your
I
hair
don't,
look good because I can't see the chat. So
oh, yeah. He said, all right, y'all, hair looks amazing. So we'll just say thank you for that. Um, But yeah, so I don't see any questions. So I mean, I don't know if any kind of closing thoughts you have about kind of the topic. I mean, anything you want to leave women veterans with if they tune in later to this live. Anything you would want to say?
oh, I think that just know that there is a sisterhood that awaits you and stuff. So that there are women, there definitely are a number of women who work in the VA who also served as veterans. There are a lot of women veterans in the community. There is a sisterhood for you that you can connect to, that cares about you and that understands your experience as a woman who served in the military and stuff. So, and the first thing is to take that first step and reach out. And like you were saying, Dr. Dooley, and is just be for those who are listening, someone who knows another woman veteran who really could utilize those services, is like, don't be afraid to be that, help that person be that bridge, basically, and help them connect to care. And that the VA really is also, it is for you. And everything, the services that we have there are for you. You have earned them through your service, and that your needs are as important as any other veteran's needs who is coming in to receive care. We're there for you.
Thank you for that. I think the only thing I would add to that is just, if you are in crisis, I know we mentioned this
Yeah.
earlier, and whether you're the family member of a person you think is a veteran that's struggling, or if you yourself are in crisis, just know that you have that crisis line that's 24 hours a day. You can always access that through phone or also through the chat or through text message. And just know that you don't have to suffer, that there is a lot of just help and hope for you. So if
Mhm.
anybody's listening who is in that place, I would just encourage you to reach out, whether it's the crisis line or help through a family member, to know you're not alone.
Mhm.
Well, Dr. Kitchen, thank you so much for being with us again. I really appreciate everything that you said today. And if that's it, we'll end our live there. Until next time.
Till next time.
All
Bye, Dr.
right, take care.